Welcome to the Parkinson's Journey program for November 2025 in partnership with the Inova Parkinson's and Movement Disorders Center. I'm John Dean. I'm a speech-language pathologist that has been specializing in Parkinson's for the past 20 years or so. This month's topic is From the MDS Congress to the Community, highlights and information about the International Parkinson's and Movement Disorders Society conference that was hosted just recently in October in Hawaii. So we're going to break down the program into two big buckets. We have a little bit of an overview of the Congress itself, the society itself. If people who don't know what the MDS is, you probably should know a little bit more about them. And then we'll dig right into research and clinical highlights with a real focus on things that you can apply right now. So we're not going to get really into any kind of bench things and petri dishes. It's going to be things that you can take and use immediately. So let's get underway with an overview of what the Congress is, and be able to do that properly. I think we need to talk about what the MDS is. And the MDS, or Movement Disorder Society, is the older term that we used to call what is now known as the International Parkinson and Movement Disorder Society. So the MDS was founded 40 years ago when a very well-known neurologist who was running the American Academy of Neurology stepped down and made a separate society focused on Parkinson's and movement disorders. And that was mainly because he saw a need to really specialize in this area and make sure that we were providing the specialty recognition and education and outreach for the community. So the society actually has 4 sections. It's all around the world. There's a Pan-American section that covers all the way from Canada all the way down to the bottom of South America. There's a European section. There's an African section. There's an Asian and Oceanic section, which also includes Australia. In each one of these groups has their regional conferences. They do some education in person and online. Like I'm going to something in Madrid in a couple of weeks for technology. That'll be an in-person program, but they'll probably also record it and have it available for people to see later on. And that's the value of the society, is that it provides quite a bit of education, resources for testing. If there's any kind of instruments that you're using when you're in a clinic, you're probably getting from the MDS, or a lot of them from the MDS. And it's basically an all-out clearinghouse for information about Parkinson's and on the whole range of other movement disorders, which could be anything. It could be Huntington's, it could be ataxia, it can be dystonia is a common one. With Celine Dion was diagnosed with stiff person syndrome. That's a movement disorder. So it covers a wide range, but they changed the name from the Movement Disorder Society several years ago, maybe 10 years ago, I guess, to the International Parkinson and Movement Disorders Society, because that really represents how prevalent in the prominent role that Parkinson's takes in that space. And so if you are working with a neurologist that is a movement disorder specialist, that means a neurologist that has undergone fellowship training to specialize in Parkinson's and related disorders, they're almost assuredly affiliated, at least a member. They may be involved in certain committees. I'm certainly involved in a lot of entities there, with the web editorial board and study groups and steering committee stuff. So it's an organization where if you are focused in this space, you're probably involved in the MDS. And if you are working with a movement disorder specialist, they are probably a member of the MDS, and hopefully members of their allied health team are also members of the MDS. So the Congress itself happens once a year. It's always at different places internationally to make it viable for different populations to show. And this year there were nearly 4,000 people. It was in Hawaii, which is a lovely location, but it was quite a distance, so it made it a little bit difficult for some folks. And that's different than the Pan-American section conference that'll happen in February, or the one that will happen in the Asian and Oceanic section. This is the big one. And this is where they bring all the latest research. You're going to hear about all the best practices. You're going to hear about the most unusual things that may be happening that you might need to know about, might need to learn something about. So every Congress is going to have their regional assemblies. I told you about the different sections. So we're going to meet. We're going to talk about the business of that society in that section, what educational programs we're going to be planning. There'll be a welcome ceremony. There'll be meetings for the business groups that are, they make their money different ways, selling tools for assessment and stuff like that. And then there are these really great lectures. There are named lectures that are really famous researchers or emerging researchers doing really interesting stuff. They have some video challenges where they're showing videos of different phenomena. We're all trying to learn from that. and networking events. And actually, our networking event this year, we had an instructor come in who was doing a study on hula for Parkinson's at the local university in Hawaii, and she actually did a live demonstration. You can't see me over on the right here. Probably better you don't see me. So there's also young professionals, young delegates. So for our younger population, we're always trying to grow leadership. I just stepped down as the chair for the Allied Health Professionals group, so I just ended my term, and now I'm focusing my attention on the web editorial board. But they have a whole bunch of them. And women and movement disorders, there's also a surgical, there's a pediatrics, there's a whole bunch of different groups like this. And then there's all kinds of sponsored sessions where maybe you can learn about the best practices for administering medications or innovative technologies or tools like that. And then what we're really here for is the educational sessions. So you usually learn about what the state is of the current practice, things that are coming, if there's any topics that are controversial, like right now they're working on a biological definition of Parkinson's, and not everyone's on board for what they want to call that. So, we work through these discussions. I remember 10, 15 years ago, we were having a discussion about Parkinson's disease, mild cognitive impairment. Was that really a thing? How are you going to define it? So we work through this as a society so that we can disseminate the best practices out to the community. So getting to the research and clinical highlights, which is really what we're here for, I'm going to kind of hit very, very high level on the medical treatments because I'm not a physician. And I'm going to say at the very outset that anything that comes up in this part of this, I really want to make sure you're talking about with your doctor. Hopefully your doctor is a neurologist. Optimally, they would be a movement disorder specialist. That means a specially trained doctor. But it is worth hearing some stuff just because we've had these conversations before. We talk about pharmacological management of early Parkinson's. It's one of these things where maybe 20 years ago, there was some discussion about where you start the meds, where you don't start the meds. And I think that we continue to see more and more evidence for probably doing it earlier with caveats. And this is why, again, you talk about this with your doctor. You don't listen to a speech therapist tell you, like, I have never seen you when this is your, this is what I think. It's about, here's what we saw at the conference. There's nothing that's going to be one size fits all. You can put two people right next to each other, same age, same general exercise background, same educational background, same work history, whatever, and they could have two very completely different treatments. And we know this. We always say, if you see one person with Parkinson's, you see one person with Parkinson's. I know we hear it so often, it's not even really a thing anymore, but it's true. You can't really generalize. Generally, they want to tell people that they should not delay, because you'll get better quality of life, you'll get better benefits, you'll probably be able to exercise better, and there doesn't seem to be a lot of benefit from delaying. It's not like you're going to have stored up this medication that you haven't used, and so when you start it, now you have less of a window before things change. What typically happens is the disease progresses, you need more medication. So if you don't use those medications and the disease is continuing to progress, you're not really winning anything with that. Now, there are often times when people you might wait and watch. This is why you're going to talk about with your doctor, because your situation is a little different. L-DOPA, carbidopa, levodopa, bensericide, levodopa in the EU and the UK. That's the first line treatment still. There are reasons why you might have somebody using another medication, particularly if they're really younger or they have kind of a higher profile with their physical activity or cognitive function or education, whatever. Those are reasons why you might change it around, but that's all for the doctor. Generally speaking, carbidopa, levodopa is the beginning one. You start low, you go slow, but you do get it into the system if it's appropriate for you. If you have to, they'll up the doses. They might add in things that can help make those doses last longer. Again, this is all doctor stuff, so you would talk about with your doctor. And then, and using the lowest dose. This is kind of like start low and go slow. That totally makes sense. And a lot of people start with, just a very low one pill 3 times a day kind of thing. Again, if you didn't start there, there's nothing wrong. Everyone's different. He started me on this pill by itself, or he didn't give me this for this, or she gave me that for this long. We started with a dopamine agonist. Those are all appropriate approaches. Your doctor works with you, knows your case history, knows your background, knows your interests and your goals and motivations, and they make those decisions with you. And that's why this is not a one-size-fits-all solution. And then to maintain ongoing follow-up monitoring, I think we're starting to see the beginnings of wearables that can provide some of that monitoring. The reimbursement's not very good right now, so you won't see it at scale. But so many studies are using wearables to track performance, not track like granularly, like how well you did it, but just how active you are, maybe some sleep stuff like that. And that's making its way. There are a number of wearables that are out there available by prescription. So monitoring will help for sure. Yeah, I mean, this is all the stuff that we were kind of going before. So your preference first, what you want or don't want, trumps pretty much everything. If you have other kind of issues, like maybe you're having some sleep issues, maybe you're having depression or anxiety or something else like that, those will affect the choice of medications, what you do for a living, maybe how physical, how outdoors, how, sedentary, and all those factors are coming here. And then how old you are, diagnosis, what kind of problems you're dealing with. When it comes down to types, we for a long time, we had this kind of two subtypes. We had people who were primarily rigid. We called them postural instability, gait disturbance, or PIGD. And then we had people who were tremor dominant. That's with AI particularly, it's getting to the point where we're getting a much broader set of phenotypes, and it's not just one or the other, but that will influence the medications for sure. I just want to hit this one more time just because it's really important that you understand that delaying the start of your levodopa will not mean that you start at a lower dose later on. It will not mean that you have less risk for motor fluctuations, those side effects, any of that stuff. So again, your doctor is going to try to start at the lowest acceptable dose after you guys have had that decision making together. But the levodopa phobia, that was a problem maybe in the early 2000s. We really have to push against it, and the research continues to push against it. It's not supported. Now, there's some techniques here. I'm cautious about this only because if you're having trouble with your levodopa absorption, if you're having this situation where the medications aren't turning on or you need to get it faster or whatever, it's very personalized. I almost don't want to talk about this because it's going to be stuff you talk about with your doctor. I mean, you can do something where they might add a dose or maybe change the timing of the dose. They're definitely going to recommend that you take it on an empty stomach. That's been the kind of the gospel for decades now. You take it either 30 minutes before or 2 hours after, and that 30 minutes could easily be 45 minutes or an hour, and that 2 hours could easily be 3 hours. It just depends. Interesting that if you can manage constipation, because when constipation, which is a very common problem with Parkinson's, you will have issues with the pill motility and therefore the pill method of action. It will not be absorbed properly if you're backed up. And there's been an interesting, every one of these conferences, there's always a case study. I didn't see this one particularly here, but I remember in Berlin, like a decade ago, they're showing someone who wasn't getting good response from the pills, and then they found in their stomach and more importantly in their intestines that it was not breaking down, and it was just stuck, and it was just not going into where it was. And they actually moved that person to a shot, an injectable formulation, and that solved that issue for that person. And this is the kind of stuff where I want to be real careful because, sure, you can always do something to make it get into your system faster. That also means that it won't last as long. So this is why I wouldn't do anything like this without talking to your doctor. I think we're all pretty familiar with this graphic. We have the motor symptoms, the things you can see on the top above the waterline, the non-motor symptoms, like sleep issues and constipation and depression, whatever, below the water lines. And then you also have complications from the medications or the disease itself. And so still at the very top line of the most bothersome symptoms in the very first 6 years, mostly motor, slowness of movement, tremor if it's present, stiffness or rigidity, and pain that would be caused by that. We didn't used to think pain was such a big part of it, but I think everyone's figured out that pain is a big factor, especially if you're dealing with not well-treated Parkinson's, if you're not taking medications and then you got some muscle stiffness, well, that's probably caused by some dystonia and the medications would relieve that. But if you're not taking it, well, then you're going to have the resulting pain, and taking some non-steroidal things might help out a little bit, but it's probably not going to resolve the root cause of it. Once you start getting into more than 6 years, then you get what we call motor fluctuations. That's when the medications don't last as long. You have to usually take more or take different combinations. And if you have more fluctuations in mood, then that's probably related to sleep changes. I think drooling is an interesting one because, as a speech therapist, it does kind of fit in my scope of practice. But my biggest concern when I see drooling is probably that there's some risk of swallowing problems, because it usually means that there's other management issues there. So if you are someone who is dealing with drooling, you are automatically at an increased risk of a swallowing problem, which means I would like you to ask your doctor for a referral to a speech language pathologist and have them do an evaluation to make sure we can head off what could be a fairly serious issue. Swallowing problems cause real serious downstream issues like pneumonia. So if you're dealing with this problem, as many people who've had Parkinson's for at least 6 years are, it's a good reason to get a referral to your doctor. Now, there have been some interesting things that have happened with surgical treatments, and maybe even things that I wouldn't necessarily call a surgical treatment. So like the older version of the pump, the duodopa in the United States, involved doing a surgery, and it would go through your stomach and then all the way into the duodenum. It would go through the pyloric sphincter at the bottom of the stomach wall. That's a surgery, and that's a very effective approach to provide kind of a gel formulation of carbidopa-levodopa, Sinemet, in a way that makes it very continuous and provides it in a slow, steady state instead of taking a pill where you take the pill, you get the benefit, and the pill wears off, and you take another pill. This is a slow and steady state. So that's been around for a while now. And more recently, there's been a pump using a very powerful dopamine agonist called apomorphine, and that actually is just a needle. So that wouldn't really be considered a surgical approach, even though it is an advanced therapy. It's more than taking pills. But the needle basically gets taped onto your stomach and provides a slow, continuous release of that. So that was around for a while, much longer in Europe and the UK, but now making its way to the United States. And then most recently, over the past year, has been a pump formulation that does the same approach. It's called a subcutaneous, and it goes below the skin. And you just put the needle in there and have some tape over it, and it provides a formulation of carbidopa-levodopa. It's very powerful. You can actually take a much higher dose. There have been other attempts to do this, but this one seems to be the one that's winning. Like there's an attempt in in Israel to do this with a company called Neuroderm that first started to make a patch. The patch didn't work. The dopamine molecules too big, never going to work. Then they figured this out, but this phospholipidopa, phoscarbidopa seems to be the superior product. Now, what's the benefits of something like this? Just Duopa, the one on the right, Duodopa, provides a significant benefit over pills. The one that doesn't have surgery, the apomorphine, provides also about that same amount. So all of a sudden you get 2 more hours of benefit than you would be with pills. One is with a surgery that's not a permanent surgery, it's like DBS or something like that, but it's a surgery where you have to have something implanted for sure. Versus something you take the needle out. With this new phospholipidopa, phoscarbidopa, particularly because you can leave it in for 24 hours, actually has an even higher amount of off-time benefit. So it's almost 3 hours. It's like 2.91. I forget the actual number. Anyways, it's more. And also people were reporting sleep benefits because you can have it in overnight, where the Duopa pump you're supposed to turn off at night. So again, it continues to improve. It's not for everybody, but it does provide a new set of tools that the doctor can help you with. It'd be worth asking them about, something you consider on the way towards other surgeries. But there are some advances in other surgeries. One that you may have seen quite a bit is this focused ultrasound. Focused ultrasound is a way to do what we call an ablation surgery, where it destroys a little bit of tissue in the brain and causes a stroke that interrupts this circuit that is damaged or not working properly in Parkinson's. We used to do that as an actual surgery using like a long probe that get heated up. Michael J. Fox actually had that procedure in the 90s. But it got supplanted by deep brain stimulation because with DBS, you could program it. And when you do an ablation surgery, it's kind of one shot and it works. They do it great. They line everything up. Cool. You get your benefits. If it doesn't do what you exactly wanted, there's not a lot of ways to fix it because you basically damaged the area. And over time, you can also continue to program your DBS and make changes to kind of coincide with the changes that are occurring when Parkinson's progresses. You can't do that with ablation. And so the benefits primarily of focused ultrasound is that you don't actually have to have a surgery where they actually do something with an electrode. They actually do it with a device externally using the ultrasound. As a speech therapist, there's some things to be careful of with ultrasound. Usually one of the adverse events is speech changes. They must always resolve, except for bilaterally, and that actually goes back to history. So bilateral focused ultrasound, this is a situation where they did it on one side and then they waited several years. They did it on the second side and they continued to have speech issues. And that was something, I mean, this is before my time as a clinician. I was interviewed in grad school when they were really doing this, but we know that bilateral surgical approaches to these ablation surgeries cause changes in speech. And some of these issues are persisting for more than a year. So that's pretty disabling. So it's not something for everybody, but there can be people that may not tolerate deep brain stimulation. They live far enough away that they can't get access to the programming, or maybe they can't handle the actual surgical side of it. So there's possibilities, but it's still a work in progress. And it's still bilaterally, if you're having bilateral symptoms, you would have bilateral DBS. That's not an option for focused ultrasound yet. I'm sure they're going to keep working on it. So when they talk about non-pharmacological treatments, in a large way, they're talking about PT and OT and speech. And they can also be talking about meditation or Tai Chi or something like that. Anything that's not a pill, and technically surgery, also non-pharmacological, although they kind of hit in that same kind of medical approaches. One thing that was great is that this year at the Congress, Day 1, Session 1 was beyond medications. They were looking for non-pharmacological approaches. Typically, this session is the practice update. I always go to it religiously every conference, and you learn what the doctors are giving medication-wise and what's the first dosage and how do you advance. And it's a great tutorial every year, and I just go there and I try not to get distracted. I just watch and learn. This year, however, they decided to just switch it up a little bit, and that session that I really liked was actually the second session, and this one was all about not only physical therapy and other interventions, but also diet and probiotics and some other factors, including some cool things like not just exercises, but cool exercise, like things that are unique, online versions or things that you're doing with technologies as well. So that's the first thing we'll say is exercise continues to be king. We know that. Everybody and their brother knows that exercise continues to be king. It's funny though, because again, 20 years ago, they weren't really talking about it. And there was a lot of discussion about how intensive it should be. And could you be possibly doing damage by doing it too hard? And yeah, I mean, you can over exercise. That's a thing. There was a session on that, not in this program, but in another session. But typically speaking, more is better. So if you are someone who is a lifelong exerciser or someone who started at least in your 40s and 50s, you were diagnosed later and you have a slower progression and you have less symptoms over time. I mean, you're still having Parkinson's, you're still going to have changes, but being active helps as you get older. And then people who started right when they got diagnosed, they were able to make pretty significant changes in the trajectory. That's the green line here, and just see where it's really trending towards the blue line of people who are regular lifelong exercisers. The black one's more theoretical, but it's kind of cool to think that if you could really motivate people to exercise vigorously all their lives, you could really, really influence the curve. And that may come if you have genetic testing that allows us to say, you're really at this much risk of Parkinson's or not. That might come down the road. But generally speaking, high intensity exercise is what it's at. And actually, they even did a little bit more on this where they went through a whole bunch of really well done studies, and they showed the ones that focused more on high intensity seemed to have better better outcomes, later time of diagnosis, lower symptom burden, as we call it, perhaps slower progression. I'm not quite ready to say that yet, but it's valuable. And, one thing that's kind of cool about this is that they do a lot of this testing when you're not on medications, kind of like if you go for deep brain stimulation surgery, they want to do an evaluation and make you off pills. They do all these evaluations, and they show that the exercise improves performance even in the off state. So it really works even when the pills aren't working, and that's kind of cool. The thing that I'm really excited about is that we've had a lot of exercise studies over the years, but they're usually pretty small. You get a small N, or you're not sure if you can replicate it. They've really started to build larger and larger studies. And so we're getting some really high quality studies like this. Slow Speed actually started in the US, but now they're doing it in the Netherlands, recruiting a large number of people who are at risk of getting Parkinson's. Either they have a genetic mutation like a LRRK2 or GVA, glucocerebridase. These are people that are highly likely to get Parkinson's, people who have REM sleep behavior disorder, at a younger age that don't have Parkinson's. Those are people who are likely to have something. And so their goal is to increase the activity over the next 2 years using an app and a wearable. The wearable really tracks performance. The app provides the exercise, and they're seeing if they can change. Can they show at this, at-risk population, can they show that this intensive exercise made a difference and kept them from getting the disease or made it happen later? And I think it's really great. Not only are they, doing the regular, testing that you would do to identify and diagnose Parkinson's, but they're getting imaging and blood-based biomarkers. So this is going to be a really great quality study. It's being done at Radboud in the Netherlands, where Josefa did her PhD, top clinic in the world. I mean, Dr. Bloom actually just got a major award recently with Michael J. Fox, top clinic in the world. So the fact they're doing a huge study with a lot of people, great sign. The SPARKS 3 is actually the third version of SPARKS, which was a high-intensity protocol that started, I think it was the University of Colorado. It was Margaret Shankman. We had a very, very tiny opportunity in that initial one. We were trying to recruit people at our facility, but they want people who are on medication, so we never got anybody at our nursing home. And Northwestern and Penn. So 3 powerhouse clinics. Now it's grown to a much larger cohort, and now they're on their third version. And their main thing is it's a dosage study. How intensive of a dose of exercise on a treadmill will result in benefits in motor performance and basically mitigating disease progression. Because again, these are people who are not taking meds. They're called de novo. So they have Parkinson's diagnosis confirmed by a neurologist, but they're not taking the meds. So the meds couldn't be influencing. This is all exercise. It's a fascinating study. I'd expect nothing less from Margaret Shankman and Dr. Korkos and all the brilliant people involved. But my first exposure was back when I was living in Colorado, and Dr. Shankman was starting this up, and it's a great study. And the fact is, they're capturing high intensity exercise over time with blood, biomarkers, DAT scans, all the great stuff you're expecting. Now, this study right here is interesting. It's a high intensity spin cycle, and this actually came from early research done by the Davis Finney Foundation with Jay Alberts. And there's a kind of a very famous story where Jay Alberts was on a bike ride out in Iowa called Ragbri, non-competitive, but it's like a fundraising bike ride for a lot of entities, not just medical, I don't think. Actually, I don't know what Ragbri's for now that I think about that, but neither here nor there. He was there. One of his patients was there with her husband, and she was on a tandem with her husband, and they were having trouble. That's common. If anybody's ridden a tandem, it's a good relationship test. And so Dr. Albert says, "Hey, I'll ride with you, but I ride really fast. You have to keep up with me." And he rode really hard with this woman with Parkinson's. That was his patient that he knew well. And they were out somewhere. It's not a competitor ride, so they're stopping a lot, and you're eating food, and they're having ice cream, and it's someone's birthday, and the pats are on a birthday card. And a birthday card, he gets it after his patient, and he looked, and her signature's improved, and he's like, "Well, that's weird." And so he does a little test with her, and it shows for sure he can see benefits. This is just from a day of pretty intensive exercise. And that became a study that they did where they actually recruited a lot of Olympic hopefuls. So this is in Colorado, and put them on the front a tandem and then made the person with Parkinson's ride the back and made them ride much harder than they would ride on their own, and showed real benefits. And this became a real watershed. Because remember, I told you before that exercise 20 years ago, they were like, don't break these people and don't work them too far. Maybe more 20, maybe late 90s. But anyways, by 2007, when they were doing this study, they were like, no, that's not true. Actually, more is better. And so in a long tail, this was a long walk for the story, and I'm sorry, but now they're doing a study using these bikes with an online class or a live class, and actually it coincides with the implementation of the Davis Finney Foundation, along with Jay Alberts and his team at Cleveland Clinic, for basically a pedaling for Parkinson's program that's being implemented in different YMCAs, and there's online versions, and so they're getting a nice bit of data on this, and their results look very promising. So very, very cool story. I love that kind of accidental science. And then I also like the fact that Jay Alberts can kind of continue to shepherd this over the course of almost 20 years to get it into people's hands. And it's not junk science. It's great data. It's great science. Okay, we just said exercise is king. Diet continues to be queen. We know more about diet, everything we already said in the past. You've been to any of our programs on diet. The prudent diet, the healthy diet, not necessarily a Mediterranean diet, although Mediterranean diet has some great data, seems to result in later onset of the disease and slower progression. And I won't get too deep in here, just to say that these are large epidemiological studies. So you got one with almost 50,000 people that they're following over a 20-year period. And then this other one here in the Rotterdam is 10,000 people. And again, prudent diet seems to really make a big difference. Probiotics continue to advance. They started with some non-human trials with a product called Simprove, which is available in the UK. Showed some really cool anti-inflammatory kind of benefits, first in a petri dish and then in rats. But now they're starting to show some promising benefits here in humans. And what's interesting is it's showing reduction in this TNF, tumor necrosis factor, which is a key inflammation marker. Interesting that there's no changes in the short chain fatty acid levels, because that's something I've seen. I've seen some kind of science adjacent BS nonsense where they do a test. Usually it's actually a stool test, and they show, like, you're missing this and you're short chain fatty acid, blah, blah, blah. And it's like, they didn't show any differences here. And sometimes I think it's not a good marker. And when you see someone trying to take something that looks like science and sell you a specialized product that costs a lot more, it's kind of a buyer beware. So unfortunately, this Simprove product is actually not available in the U.S. or easily, and hopefully they'll have something that comes here. But I think that we're also seeing smaller studies on humans over here that's showing other general off-the-shelf. I remember Mark Halb at the University of Kansas was doing that research. Ray Chowdhury was doing one. I think Dr. Chowdhury might have been on the Simprove because he's from the UK. So cool. Probiotics may have some benefits. Certainly not doing any harm. Doesn't seem like there's any particular benefits for a particular brand, except that the Simprove is a high-quality one, and they are trying to regulate it carefully. This is just interesting because there was a short-term study that showed shifting from an African diet to a Western diet caused real significant inflammation, weakened their immune responses, and made things look like they might start a disease process. The 2 weeks, you can't really tell. But switching back actually showed noticeable improvement. It kind of reminds me of that documentary called Super Size Me with Morgan Spurlock, who made a pledge to eat McDonald's for breakfast, lunch, and dinner for an entire month. And anytime they asked him if he wanted to supersize it, he would. And he got not all the way through a month, and his body was making him feel really sick. And his doctor was looking at his liver numbers and saying, "You got to stop this. You're just getting me very sick." And it's just kind of a reinforcement of that. So prudent diet, getting away from highly processed Western foods, probably good. We know this also. This is not actually at this conference, but this study came out earlier this year. Same thing. Ultra processed foods lead to a higher link with prodromal symptoms before diagnosis symptoms of Parkinson's. Last thing in the diet, and I don't want to get too far down here, ketone esters are being used as a supplement by elite athletes. And if you've heard about ketogenic diet, there's some potential for benefits for Parkinson's, with the reality that could be a little bit of difficulty managing. So this is actually a supplement drink that they're testing now. And what they showed is that people who were drinking this drink were able to have a much higher endurance when they were doing spinning, and also increased their VO2 max, although not significantly. So this is interesting. It's not here yet, but I could see something coming down the road where it could make it easier for someone with Parkinson's to exercise with a level of intensity that's needed to maintain or reduce the progression of the disease. I'm going to go into this very quickly with the other treatments. I wanted to say that AI is everywhere. I kind of got tired about it because it's become such a buzzword that it shows up in every product. Oh, they're making this, or have a subscribed, so it's making your reports for you. I will say the three big areas that you're really seeing: machine learning for visual things, whether that is movement from a camera or an image from a CT scan or something like that. It's really making huge gains, and they're able to diagnose things and phenotype people in a way that they never could before. AI scribes, meaning when you go to your doctor's office now and they're recording everything and they don't have to spend too much time sitting at a computer. That is machine learning being used to record your voice, and then using speech recognition and then processing that with a large language model. Those are really coming along. And then, again, I see a lot of outcome measures where they're still getting their traditional outcome measures, but now they're using digital tools like a wearable, and that's interesting. I won't get too far in this because I'm going to actually do a whole session on technology in an upcoming program not too far from now. So I'll just kind of give you the highlight of one of the more interesting things I saw there. That's kind of cool. So Amped PD is actually a project that comes from a startup called MedRhythms, which is focused on kind of a music therapy approach for treating Parkinson's. And there's some interesting research, actually, initially from Colorado, Michael Dowd, but now it's been turned into more of a product that you can use. And so one thing they've noticed is that, you have the metronome help people use better gait, and then they figured that music can also do that as well. But what this company's done is they put music into an app where your headphones, and it recognizes your tempo with the movement because it's got these little sensors on your feet, and then it basically makes the music sync in there, and then trains you, and then slowly speeds it up till you get to a level of intensity that you're supposed to, because we don't want lower intensity exercise. If you're walking, they want a certain pace. And then if you lose your entrainment, if you get a little bit off, then it slows down and gets you back there, and then slowly works you back up there. Very slowly in the background keeps working to push you. And what they found that's kind of cool about this is that only the people who are using the device were able to get to the right level of intensity for 30 minutes a day, 5 times a week. And when they removed the devices, it went right back to those levels that they were at before. So I think that's interesting. So I have a lot of high hopes. It's I've been following that MedRhythms company for a while. They've done really interesting stuff. They got an FDA approved for an app for stroke, and they're actually working on this app right now for Parkinson's. They've raised a lot of money, and a big chunk of it, like more than, well, probably not quite half, like 30% of it, 40% of it, tens of millions of dollars went to music licensing, because they figured out that you have to have music that you like. It can't just be some kind of generic canned music. It has to be something that has resonance and emotional connection, and that's interesting. So I'm looking forward to see what they do next. So I'm going to leave it here. Again, I tried to be real careful with the medications because I am not a physician. And even if I was a physician, I'm not your physician. But I think that my takeaway is that this Congress is the annual event for people specializing in Parkinson's. There are other congresses around the world. We'll go to some of those other congresses, but this is the one that I think most of us are focused on. It has the most educational material. And if you're working with a mood disorder specialist, they're probably part of it. Like I saw Dr. Falconer from the Nova Parkinson and Mood Disorder Center. He came here to do a presentation. It's the place for experts, and that's why we're a part of it. And that's why I think you should be seeing that your people are a part of it too, because they had the best information. And I'm biased. I do a lot of work for them, and I'm on a lot of committees for them, and I'm their web editor, and blah, 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 blah. But I've been to a lot of the other ones, and this is the one that really provides the most resources. So I'll leave it here. Thanks for coming. If you have any questions, don't hesitate to reach out. And if you're a nerd and you wanted more technology, I got it covered. It's going to take a little time to put some stuff together, and I wanted to wait until I went to the program in Madrid, but I'm coming with it. All right. Thank you.